Hello everyone. Today topic is organ transplant rejection. I am Brinda Ronika, working as a tutor in Tribhulam College of Nursing. By the end of this section, you should be able to define organ transplant rejection, enumerate its causes, list the different types of rejection, describe the clinical manifestations, explain the management approach, and finally elaborate on the nursing care involved. Keep these objectives in mind. We'll come back to each of them. Let's start with the basis. Organ transplant rejection is essentially an immune response. The recipient body recognizes the transplanted organ as foreign and mounts an attack against it. This is important to understand. Rejection can happen at any time after transplantation. It is not limited to the first few days. It can affect how well the graft functions and ultimately whether the transplant survives long term. That's why early detection and prompt treatment are so critical. They directly determine the transplant outcomes. Now we'll move into the definition. Transplant rejection is an immune response in which the recipient body identifies the transplanted organ as foreign and attacks it. This happens because the donor organ carries different antigens than the recipient's own tissue, and the immune system is designed to detect and destroy anything it identifies as non-self. Okay, now we'll move into the causes. The main causes include an overactive immune system response, HLA mismatch, meaning the donor and recipient tissue types don't match well. Next one is the inadequate immunosuppressive therapy, not enough medication to suppress the immune attack. Next cause is non-compliance with medication, a very common and preventable cause. And the last one is previous sensitization to donor antigens, meaning the recipient body was already exposed to similar antigens before. Now we'll move into the main thing, types of rejection. There are three main types are there: hyperacute rejection, acute rejection, and the last one is chronic rejection. Okay, the first type is hyperacute rejection, the most rapid and severe form. This occurs within minutes to hours after transplantation. It happens because the recipient already has preformed antibodies against the donor antigens, often due to blood group incompatibility or prior sensitization. These antibodies immediately attack the blood vessels of the new organ, causing clotting and cutting of blood supply. Unfortunately, hyperacute rejection is largely irreversible and the transplanted organ usually has to be removed. This is why cross-matching before transplant is so essential. It helps us catch this risk in advance. The second type is acute rejection, which is the most common form we encounter clinically. It typically develops over days to months after transplant and is primarily a T cell mediated immune response, the body cellular immunity attacking the graft. The encouraging part is that acute rejection is often reversible if detected early, usually managed with increased immunosuppressive therapy. This makes close monitoring in the initial months after transplant absolutely essential. Next, we'll move into the third type. It is a chronic rejection which develops slowly over months to years. Unlike acute rejection, this is a gradual progressive process involving fibrosis and scarring of the graft tissue. It is a leading cause of long-term graft failure, and unfortunately it responds poorly to treatment once it sets in. This is why long-term follow-up and medication adherence are so important. We are trying to prevent the slow decline in organ function. Okay, next one is signs and symptoms. Across all types of rejection, nurses need to watch for certain warning signs: fever, pain, or tenderness at the graft site, swelling, reduced urine output in kidney transplant, unexplained weight gain, and a general decline in organ function. Recognizing these early clinical clues is often what allows a medical team to intervene before permanent damage occurs. Okay, next one is to confirm rejection, several diagnostic tools are used, thorough physical examination, blood investigations, organ function tests like renal and liver function panels, imaging studies, and the gold standard tissue biopsy, which gives us definitive confirmation of rejection and its severity. Okay, now once rejection is confirmed, management focuses on suppressing the immune response. First one is immunosuppressive drugs such as tacrolimus, cyclosporin, mycophenolate, mofetil, azathioprine and prednisolone. And next one is a high dose corticosteroids for acute episodes. And third, we can give antibody therapy in more severe and antibody mediated cases. Next, plasmapheresis, like to removal of harmful antibodies from circulation. And the main thing it is continuous monitoring to track the patient response to treatment. Okay, now very important part, nursing care. So as a nurse, what we have to do means monitor vital signs, graft function and lab values, and stay alert for early signs of rejection like fever, pain, swelling, weight gain or reduced organ output. Next one is administer immunosuppressive medication exactly as prescribed and watch closely for side effects and complication. Third responsibility is maintain strict intake and output records along with daily weight and fluid balance monitoring. And next one is prevent infection. Remember, these patients are immune suppressed, so aseptic technique and infection surveillance are non-negotiable. And most importantly, educate the patient about lifelong medication adherence, keeping follow-up appointments and reporting any abnormal symptoms promptly. Patient complaints is often the single biggest factor in long-term transplant success. Let's summarize it. Organ transplant rejection is the body's immune reaction against a transplanted organ, occurring as hyperacute, acute, or chronic rejection. Early recognition, proper immunosuppressive management, and above all, strong nursing vigilance and patient education are what ultimately protect the graft and the patient.